the sepsis slides first. Okay, so then let's get started with the lung transplantation. And I'll start with a brief overview. I usually mention this at the beginning of each presentation. I have no financial disclosures to make. I usually put a slide in there, but I didn't today. Maybe on the next slide set, I'll have that lecture, but I have no financial disclosures to make. I have no financial affiliations with anything that we're going to talk about today. And to start with the brief overview, we're going to talk about general concepts of lung transplantation, talk a little bit about recipient selection and donor selection, and maybe a few words on post-transplant complications. And I understand that most of you guys are probably not very closely involved with lung transplantation, so I'm not going to try to delve into a lot of details and depths of lung transplantation, rather give you a general overview of how to approach recipients, B, donor selection, and then maybe a couple of words on what these people actually have to go through once they receive lung transplant. So here's some sort of simple slide, simple diagrams, graphs, more for demonstrative purposes rather than showing you the true statistics of lung. If we take this first box on the left and we look at the survival of individuals that are on wait list for lung transplantation, you can imagine that over a period of time, some of them died before receiving lung transplantation. And again, there's no timeline here, just demonstration purposes that over a period of time, these individuals, like everybody else, will probably succumb to their disease. The idea of transplantation is here in the middle part, that once we transplanted these individuals, their survival will be better and their survival curve will be less steep, but more of them will make it out 5, 10 number of years after the transplant. The true transplant benefit lies between these two graphs. The graph on post-transplant survival, it's got to be better than the graph of waitlist survival. If there's no difference or there's no significant difference, then there's no point of transplanting these individuals. So the money, if you will, or the survival is between these two graphs. So let's really quickly try to examine these graphs. So the next one here is similarly for demonstrative purposes. This is not statistical in any way. Here we have time on the horizontal axis. There are no numbers of years. And here we have survival on the vertical axis. So you see that the pre-transplant survival on a wait list has relatively steep curve. And that curve kind of steepens or deepens immediately after transplantation. The first few weeks, first few months post-transplantation, many people suffer from significant morbidity and sometimes mortality of the lung transplantation itself. You have to imagine that lung transplantation is a very different process than kidney transplant, maybe even liver transplant. So many patients exhibit and suffer from morbidity and mortality of the transplantation, and sometimes the lung transplant becomes worse than the pre-existing disease was. And that general concept that lung transplantation is not like kidney transplantation. Lung transplantation is not like my shoes are worn out, I'm going to the store for a new pair of shoes. Understanding that lung transplant is a disease in and of itself will help us understand a lot of these concepts that we're going to talk about. And then obviously post-transplant, as the time goes on, the patient survived that initial sort of shocking, literally and figuratively speaking, once the transplanted patients survive the initial shock of transplantation, then their survival really over the next few years does get better than pre-transplant. I'll get to next few slides. I'm going to show you some simple statistics derived from the government report. So this is total for United States. And a couple of things that I'm going to mention here on this slide, we're going to talk about again later on when we talk about Lung Allocation Score and how the lung available lungs for donation are being allocated. So here on this slide, you can see from the legend, these greenish X little signs, those are individuals with IPF or other restrictive lung disease that are transplanted. The blue line is that obstructive, mostly COPD patient, and the other colors, they're down on the bottom, they don't contribute very much in terms of the numbers of transplantation. You see that over the period of the last 10 years or so, from 2010 to about 2021, I think this is the last one that I had available in terms of the statistics, the percentage, the proportional rate of patients with IPF or other restrictive lung disease increased in terms of who's getting the lung transplant. Patients with IPF rather than patients with COPD are getting transplanted, and we'll talk about when and how that happens. Here is the total lung transplant race, and this is more about understanding the societal differences or societal reasons why certain individuals in this situation, whites compared to the other races, why white individuals get transplanted a lot more, dramatically a lot more than individuals who are. Nothing medical here, it's probably more societal reasons. Here is the male versus female ratio, and again, there's some predominance of males. Maybe they have more disease, or maybe they have more severe disease, but clearly male patients get a lot more lung transplant. Lung transplant by age. We'll talk about age and limitations of age when it comes to whether or not someone will be a good candidate for lung transplantation. And here, majority of the lung transplants are happening in individuals that are considered middle-aged or maybe older. So the bluish X signs are individuals 50 and 64. That's probably considered middle-age. And then 65 and plus, I don't want to offend anyone, but little more than middle-age. Let's not call them older people, little more than middle-age. Again, majority of the transplants are happening in the age category somewhere between 50 plus, maybe 50 and 70 or so. And again, I'll mention a little more detail of who will be or should be getting lung transplant based on their age. So moving on a bit from general statistics, general stats, the lung transplantation, and talking more about recipient selection. So who should receive lung transplant? I mentioned earlier that patients with IPF or restricted lung diseases in general get the lion's share of lung transplantation, get the lion's share of all the lungs being transplanted today. And that's probably for a good reason. So what should these criteria be that determines who gets the lung transplant? First of all, there's got to be medical individuals that are sicker should be receiving lung transplant more urgently, more expeditiously than the ones that are not as ill. Okay. We also don't want to transplant individuals that are not going to benefit from, in the sense that they are maybe at the end of their life, and we don't want the individuals to do lung transplantation and then die within 6 months or so. So we have to select them as pretty sick, but not so sick that they're not going to survive. Kind of obvious what they have mentioned. And we want to minimize the waiting. So if someone goes on the waiting list, we don't want that individual to stay on the waiting list for too long. These reasons, for these three sort of major reasons how to select the patient, the Lung Allocation Score was developed in the early 2000s. Lung allocation changed dramatically somewhere between 2004 and 2005. So 2004, individuals that spent the most amount of time on the wait list transplanted. In 2005 or so, we came up, not myself, but the Transplant Society came up with the Lung Allocation Score that allocated lungs slightly differently, not based on the wait list only, but also based on those clinical criteria that we're going to dive into in a minute. So the New World Order in terms of lung transplantation, Lung Allocation Score, came in about 2005. This was modeled a little bit after the MELT score. If you guys are familiar with the liver transplantation, MELT score is a very important factor in determining who should get liver transplant and who should not. The idea of the LAS, Lung Allocation Score, was to estimate the risk of death on the waiting list. So if we have individual that, because of the nature of their disease, is likely to die from their disease sooner than another individual that spent a longer time on the list, we want to give preference, we're going to give priority to the sicker person, even though that individual may have spent less amount of time on the list. So kind of to reiterate that long and complicated sentence, time on the wait list did not become the main reason why someone did transplant. Okay. The other important factor was to estimate the risk of death after transplant. So if someone was more likely to die with the transplantation, obviously that individual was moved down on the wait list or moved down on the priority list compared to the other. One of the biggest sort of the grinding point or friction point became between the individuals with IPF or restrictive lung disease and individuals with COPD. Now you can imagine, I'm sure you had clinical experience, that even the sick patients with COPD with advanced disease typically have longer survival than individuals with restrictive lung disease, such as that. So for example, someone with comparable lung function or comparable PFTs with COPD would live a lot longer than individual with similar PFTs who has IPF. And that's more about the nature and the natural history of one. So we thought that it was better to transplant with IPF, even though they may have had comparable severity of the disease, because patients with IPF would progress much faster. A total of 17 variables were considered initially for LAS score: age, BMI, underlying diagnosis, presence of pulmonary hypertension, 6-minute walk test, renal function. I selected some of the sort of bigger, more important ones. Obviously, there are a lot more because there were 17 variables. And we very quickly realized that after moving to lung allocation scores to properly allocate individuals, the mortality on the wait list dropped dramatically by 20 to 40%. So simply giving priority to patients with IPF changed the landscape of how lung transplantation was being done and changed the mortality of individuals wait list. Very quickly, that allocation process was adopted by many countries in Europe. We're talking about lung allocation scores being sort of developed and first implemented in the United States in 2005. Germany followed suit in 2011, Netherlands 2014, Italy 2016, and so on. In the United States, we had a little bit of an update and kind of tweaking of those criteria and of those guidelines in 2015. And again, the details of those, how different the 2005 was from 2015 is really not a big part of what I want to talk about today. So I'm not getting into compare and contrast of what we did in 2005 versus what we were doing in 2015. The idea is that the change to LAS, to lung allocation score, again, changed the landscape of patients getting transplanted in the past to patients with IPF getting now. And as you can see from the statistics that I've shown you before, the IPF patients outnumber COPD by a factor of 2 to 1, maybe 3 to 1. So nowadays, about 60% of the countries worldwide use some version of lung allocation scores in their ways to determine who should get first. Here's more descriptive, if you will, or more visual way of comparing who was getting transplanted before LAS and after LAS. And this is immediately with the change. So the before LAS, majority of the transplantation was being done in the COPD patients. Then we had a small sliver of pulmonary hypertension, a relatively large size of patients with cystic fibrosis, and IPF contributed maybe 1/3 of all patients with transplant. In 2005, right at the inception of Lung Allocation Score, you can see that the proportional number of patients with COPD getting transplanted shrunk by half, and similarly, IPF patients in twofold. And as we saw already earlier in this presentation, the current ratio is more 3-to-1 between IPF. Nowadays, IPF patients take the lion's share of all transplants. So what are the general criteria for selecting someone lung transplantation? Who do you want to send to a lung transplant center for possible consideration for lung? Obviously, someone at the more advanced stages of the disease who has high risk of death from the lung disease without the transplantation. We want that individual to be relatively healthy and be able to survive the surgery. We don't want someone at the end of life to go through the pain and suffering, if you will, or morbidity and mortality, if you will, of undergoing lung transplantation. If the person has 80% or better chance of surviving 90 days post-transplantation, and obviously this is all projected based on their overall medical status, then we want them on the transplant. The other important factor is that we, in addition to their lung disease, we want to evaluate the patient as a whole and make sure they don't have other types of cardiovascular or renal or other metabolic diseases that will make them poor survivors longer. So because of their cardiovascular disease, someone may have 50% 5-year mortality, and obviously we don't want that individual on the lung transplant list, because the benefit that individual will derive from lung transplantation limited or curtailed by the fact that their cardiovascular disease soon. So these are, again, general thoughts, that general ideas. Who do I want on a transplant? Someone that's reasonably sick, but not too sick, and also someone that has rapidly progressive disease, such as IPF, rather than relatively slowly progressing disease. Some general contraindications to transplantation, obviously malignancy, recent malignancy or ongoing untreated malignancy is going to be a big no-no in terms of transplantation. Other major organ failure, liver failure, cardiac failure, severe atherosclerosis, that will decrease someone's survivability over the longer period of time. Some type of unstable medical condition. We don't want to pluck someone from the ICU who's on dialysis and ventilator for some other reasons and send them to lung transplantation. And most of these kind of make sense as we go down the list of absolute contraindications, things like uncontrollable bleeding, how we're going to put that through a major surgery, chronic infection with virulent or multi-drug resistant organisms. Obviously, after lung transplantation, we receive heavy doses of infection. So infection is a big no-no in that situation. Chest wall or spinal deformity is going to be another big one. There is sometimes difficulty in terms of matching the size of donor to the size of the recipient. So either having a very large size donor, and that donor lung may not be able to fit into a small individual's chest, or the other way around. We have a relatively small size donor, a petite person, and a smaller lung going to a large individual. Important to maintain that general size matching. And in people with some type of chest wall or spinal deformity, the lung transplantation also becomes quite difficult. Another contraindication, not necessarily an absolute contraindication, but a relative contraindication, is prior thoracic surgery, because the assumption is that if someone had a surgery on the chest cavity will be somewhat abnormal and may not be very well. Extremes of weight never works too well, and we're usually talking about someone with a BMI of between about 17 and about 35 or so. So anything after 35 is a no-no. 30 to 35 in terms of BMI is a maybe, but kind of big maybe, and also very, very thin and cachectic patients don't do surgery with the transplantation. So social support is an important one, and that's same for all patients with transplantation. We often replace one disease with another. These individuals have to be on long-standing immunosuppressive medications. So if they don't have social support, if they don't have good insurance to pay for their medications and for their medical visits, they don't have good social support system, typically that becomes a big hurdle lung transplantation. So that's an important one as well. And obviously substances, whether it's tobacco or alcohol, or other types of illicit drugs, that kind of substance dependence never of transplantation. So there's a long list of these contraindications. I don't expect you to remember all of them, but I think a lot of them kind of make sense. So you can imagine why these would be not good candidates. So some of the relative contraindications we already talked about, and remarkably, age is one of those. It used to be that certain age limit was set through transplantation, and now we simply say that age number. So a good, healthy, strong 70-year-old may be a better candidate for lung transplantation than 55-year-old with previous smoking history or some other medical conditions like diabetes, renal failure, etc. We talked about obesity, that mild obesity with the BMI somewhere between 30 and 35 may not necessarily be a big contraindication, but it would be something to kind of give you a pause and thought a little bit, and maybe not necessarily consider transplantation in a very heavily individual. Again, most of the things on this list kind of generally make sense. We don't want, we don't want someone with malnutrition or osteoporosis to have that. We spoke about thoracic surgery for a little bit. It's not an absolute contraindication, but again, someone probably pause and think twice about transplanting someone who has thoracic surgery. Hepatitis B, hepatitis C, HIV, other types of bloodborne infections used to be a absolute contraindication, but nowadays we have reasonably good treatment for all of those diseases, so they no longer are absolute contraindication and kind of move down to a relative contraindication. As long as their disease is under control, those individuals can be considered for transplantation. Okay. Atherosclerosis we talked about, and other medical conditions without organ damage. Again, it's total person evaluation. A little bit of diabetes or a little bit of renal failure may not necessarily dissuade the transplant surgery for transplantation. But let's get into a little more details of each group of individual lung disease. We're using only 4 big groups here. IPF as a representative for interstitial lung diseases. We're going to use COPD as a representative for obstructive lung diseases. We'll talk a little bit about cystic fibrosis and a little bit on pulmonary hypertension, because in my opinion, these 4 groups or these 4 diseases contribute largely to the general population that's transplant. For patients with IPF, indications for referral and then indications for listing. And we typically say that someone with a diagnosis of IPF should be referred to a transplant center at the time of that. Main reason for that statement is that these individuals have very progressive disease. They often get diagnosed late in their disease process. So it's very important that we catch them early and we kind of get them to the transplant evaluation, to the transplant relatively early, so they actually get a chance to be listed and be benefited from transplantation. For indications for referral, FVC less than 80% predicted, or DLCO less than 40% predicted, basically at the time of diagnosis. So anyone with diagnosis of IPF will likely have these numbers as their criteria. Any functional disability due to lung disease. Again, I can't imagine someone being diagnosed with IPF and going skiing at the same time. So basically, anyone with diagnosis of IPF can be referred time to time. Then indications for listing for transplantation: decline in FVC greater than 10% in 6 months, or similarly decline in DLCO greater than 15% in 6 months, decline in 6-minute walk distance, 250 meters total, or decline more than 50 meters in 6 months, and so on. Anyone that gets hospitalized related to exacerbation to IPF can be a trigger to list. And again, this is done because we think that IPF is a very, very rapidly progressive disease, and we have to catch them early, so we have a chance to intervene and help with transplantation. And perhaps this is one of the reasons why majority of the lung transplantations nowadays are getting done on. So, kind of remember these general numbers as far as FVC DLCO goes, and let's try to compare that to that of COPD, which is, I think, is coming up. For patients with COPD, indications for referral are progressive disease. Okay, most everyone have progressive disease. But not a candidate for lung reduction surgery. And here we have to put lung reduction surgery with a little bit of an asterisk, because lung reduction surgery, the open surgery, well, has largely fallen out of favor. And what's in a lot more in favor is the bronchoscopic lung reduction surgery, or bronchoscopic lung reduction. If the patient is not a candidate for lung reduction procedure, whether it's bronchoscopic or open surgical, then that would be a good individual for referral. Body index, I'm sure you know what the body index is. Body index somewhere between 5 and 6, PCO2 greater than 50, and or PO2 less than 6. And here goes FEV1 less than 25% predicted. Remember, the indications for referral for IPF patients was pulmonary function test less than 80% predicted. Here, by comparison, FEV1 less than 25. So we basically want a lot sicker COPD patients. COPD patients at a lot more advanced stage of their disease compared to the IPF patients. The COPD patients, their natural progression of their disease is much slower. So we have a lot of time with them. And perhaps they will outlive their peers with lung transplantation because their disease is not very. Try to transplant people with COPD at a lot later stages of their disease as compared to the patients with that. So indications for listing here will be body index greater than 7, FEV1 greater than, FEV1 is less than predicted, one severe exacerbation with respiratory failure or significant pulmonary hypertension. So compare and contrast IPF with COPD. A lot sicker COPD patients are getting transplanted, and IPF patients being transplanted at earlier stage of their disease. A couple of words on pulmonary hypertension, and I think I have another slide on cystic fibrosis. These diagnoses contribute a small percentage to overall lung transplantation patients, and to some extent it has the main reason for this is that a lot better treatment for pulmonary hypertension that we had 20 years ago, and similarly CF patients lead a much longer and healthier life than 20, 30, 40 years ago when I was a medical student. So the advances in treatment of pulmonary hypertension and cystic fibrosis also has affected the type or the timing of their referral to transplantation and the timing of their referral listing. So pulmonary hypertension, New York Heart Association functional class 3 or 4, so that's pretty advanced. That's basically rapidly progressive disease or need for IV medications. You may remember pulmonary hypertension. Nowadays, we have 3-4 different medications, oral medications, very well tolerated medications, as opposed to the IV meds that we used to use before. So use of IV medications will be a referral, will be a indication for referral. Many of these patients are nowadays maintained on oral medications for many, many years. So need for lung transplantation in patients with pulmonary hypertension has also dramatically over the last few decades. Indications for listing for transplantation in patients with pulmonary hypertension would be cardiac index less than 2. That's pretty bad cardiac index. Mean right atrial pressure more than 50 millimeters of mercury. That's basically right heart failure. 6-minute walk distance less than 350 meters, or significant other manifestations of disease such as pericardial effusion, hemoptysis, progressive failure, etc. Pulmonary hypertension by itself is a relatively uncommon disease. And like I said, with the new advances in oral treatment, oral medications for the treatment of pulmonary hypertension, the need for transplanting these individuals has become more. And probably the same goes for cystic fibrosis. We're learning better ways to take care of these patients. Unfortunately, these are younger individuals, ones that are very sick very early in their lives. So it's really important to get them onto the listing early. However, there's a little bit of a sort of bright light in this because I was just very happy to hear that they started the gene therapy for individuals with sickle cell anemia. And hopefully we'll very quickly, very soon, we'll have some good news with that, and hopefully we can use that patient. So indications for referral for cystic fibrosis is FEV1 less than 30% predicted, 6-minute walking distance, 100 meters, presence of pulmonary hypertension, or clinical decline with frequent exacerbations. And then indications for listing, similarly, chronic respiratory failure, long-term positive pressure ventilation use, rapid lung function decline, or WHO functional class that rise. Now, I kind of ran very quickly through these 4 big groups of diagnosis in terms of their indications for referral and then indications for listing for lung transplantation. To me, the biggest comparison is between the IPF and COPD, and why we're choosing to list and transplant the patient with IPF much sooner than we're doing for patients. So now I'm going to kind of wrap up that part about the recipient selection and talk a little bit about donor management. And I'm imagining that individuals, those of you who are working in the ICU, you probably interact with potential donors a lot more commonly than you interact with potential recipients. So let's see how we can manage the donors a little bit better, so then we can help those that are waiting for the lung transplant on the wait list. So here's a old slide that I had saved that I think represents pretty well how we do with various solid organ transplantation. And this is out of all the suitable donors, out of all the individuals that had given the gift of life, how many of those that were solid organ donors become kidney donors versus liver donors versus heart donors versus lung. So you can see that the percentage of individuals who are donors, are solid organ donors, smallest percentage of them do become lung donors. And there's a number of reasons. And I'll try to go through most of them, and then we can talk about how we can make that percentage of lung donation out of all suitable donors a better number. How can we improve the percentage of individuals who are donors that eventually become lung? So there's this thing of ideal donor. It's probably one of those words that carry this certain weight, if you will. So yes, we want the ideal person as our life partner. We want the ideal lung donor to give lung to our patient. Those things are kind of hard to find. So we put together this list of criteria that will describe someone who is ideal lung donor, but the likelihood of such individual, the likelihood of such donor existing is relatively small. You can imagine that out of the entire donor pool, lung donors, remember all donors, 20% of them become lung donors, and then 20% lung donors, 20% of those are ideal lung donors. So out of the big pool of individuals that are giving the gift of life, very, very small proportion of those individuals are actually ideal lung donors. And here's a brief, or maybe not so brief, list of ideal lung donors. We want them to be young, we want them to have normal lungs, clear chest x-ray, we want them to have normal gas exchange, we want them not to have chest trauma, not to have aspiration, not to have sepsis, not to have purulent secretions on bronchoscopy, not to have any organisms on gram stain. And as you're probably thinking about the last patient you had who was perhaps brain dead, becoming an organ donor, you can imagine that probably haven't had too many of those patients fill all the first 5 or 6 criteria that I mentioned, not to mention more criteria as we go down the list. So this whole concept of ideal donor is a little bit of pie in the sky. I think that a better way to look at the situation is, how can I make this patient who's perhaps brain dead, who has become a donor, how can I maximize likelihood that person donate the lung, and that lung being donated will then help another individual. Forget who's ideal and who's less than ideal and who's not so ideal. Let's talk about how we can maximize the benefit of transplanting lung and improving the chances that that lung will actually help. One other important factor that these criteria for the ideal lung donor, or I should say ideal in quotation marks, these criteria for ideal lung donor has never been supported by literature. So nobody knows whether or not these are the proper criteria. As very much appropriate, clinical judgment is often substituted instead of this long list of ideal. So then who is non-ideal, and how can we, like I said, improve or maximize the likelihood of procuring those organs for transplant? Extended criteria donors, this kind of fancy word has been used to sort of move away from ideal donors and maybe distinguish those individuals that don't fill all those criteria to become an ideal donor. And what's important here, that at least one marginal factor will be present in the majority of donors, but very rarely do we have lung donors. We would like to have them being donated, the lungs being donated after brain death, with the pumping and fusion still happening kind of in vivo. However, in the recent years, more and more often, there are lungs being donated after cardiac death. And I don't want to belabor the point of what's the difference between the cardiac death and brain death. You can imagine that individuals with brain death have been declared dead by neurologic criteria. The brain death is a colloquial term for it. So individuals that are declared dead by neurologic criteria still have their heart pumping, still normal perfusion is happening, and we then take them to the operating room and explant the lungs, remove the lungs from the donor, and then those lungs are pushed to another institution, usually for transplantation. Now, in cardiac death, what's happening is the following. A patient is being removed from the life support because of various reasons. And if the cardiac death happens within a certain amount of time after the removal of support, supportive care, of supportive measures, then that individual can potentially become donor for solid organs. The criteria for who will become a donor after cardiac death is so very different based on different approaches and different individuals and different surgeons. So that's another discussion in and of itself. But you can imagine that lungs donated after cardiac death are arguably less ideal than the lungs donated after brain death. So the individuals donating lungs after cardiac death fall under the category of non-ideal donors. And then there is one more kind of wrinkle into this, which is use of previously thought unsuitable donors after ex vivo lung perfusion. Not only do we take the unsuitable, or thought to be unsuitable lungs, but then we run these lungs into a device that perfuses them and perhaps improve perfusion, improve their gas exchange. And after running that ex vivo lung perfusion for a certain time, reevaluate those lungs and determine whether or not those lungs can be suitable donation. So you can imagine that this is whole new concept, whole new world opening up in terms of ex vivo lung perfusion. And so far, the evidence is relatively positive, relatively promising that ex vivo lung perfusion may actually make some unsuitable donors back into. So here's that whole sort of timeline as the ideal donor comes into the view. Someone is declared brain dead and has relatively good gas exchange and can be a good donor for lungs. Eventually, as the time goes on, may develop infection or other complications that are common in critically ill patients, and then over periods of time become unsuitable donor. And the idea of ex vivo circulation or ex vivo lung perfusion is kind of reverse that timeline, if you will, and take some unsuitable donors and make them more suitable because they've been perfused and because they've been improved in terms of their physiology. Too much to talk about here. Lots and lots of interesting things happening in that arena, but probably way, way, way off topic of discussion that will just kind of giving you some ideas that even the individuals that would be considered poor or unsuitable donors yesterday may very well become donors tomorrow. So I'm talking a little bit in the next couple of slides about why lung recovery is so bad. Why only 20% of individuals that become donors eventually become lung donors. So first of all, resuscitation maneuvers. There's IV fluids, CPR, what have you. The treatment prior to them becoming a donor typically is not beneficial to lung. Many patients will also develop neurogenic edema. Again, what majority of the patients donating organs are probably those that have been declared dead by neurologic criteria. And neurogenic edema, neurogenic lung edema, is a very, very real thing. You can imagine that many of these individuals have some type of aspiration event, if not full-blown aspiration pneumonia. Ventilator-induced lung injury is a very, very real thing in these individuals too. And in many situations, the ones that become donors who become brain dead had severe neurologic injury prior to them becoming a donor. And typically these individuals are managed, ventilated in a not lung protected, not lung beneficial way. Imagine that many neurosurgeons or many neurologists that take care of these patients prior to declaration of brain death did not really take good care of their lung. So it's not uncommon for these individuals to develop ventilator-induced lung injury or ventilator-induced pneumonia or many other types of critical care pulmonary illness. Pulmonary embolism is also very real and very common thing. There are actually some ideas some thought into removing or treating pulmonary embolism in patients or in lungs with ex vivo lung perfusion. The lung is being perfused after removal from the donor. It's used with medications with substances that will remove pulmonary embolism potentially. A lot of exciting and interesting things happening in that arena, as you might imagine. Today is not a good time for me to discuss. A couple of words about brain death and how that impacts lung recovery. There's a lot of hemodynamic stuff here. I'm not going to get into a lot of details of that. There's autonomic crisis. There's a lot of humoral dysregulation that's happening in these patients. Many of them will develop typical CHF, hydrostatic pulmonary edema. They will have some degree of surge cascade, and many of them will have ARDS type of illness. So many critically ill patients that become brain dead, that become organ donors, will not be suitable for lung donation for these various reasons. It's important that limit the use of fluids for hypotension in these individuals. It's important that we use diuretics. Sometimes they don't like diuretics because that impacts the kidney survival and impacts the likelihood that individual becoming a kidney donor. So there are lots of conflicting ways that we can manage the donor, and sometimes those ways of donor management are not necessarily long beneficial. Other types of management after brain death typically include steroids and thyroid hormones. Those may or may not be long beneficial or long protective. And then there are important ventilators that should be long protective to prevent atelectasis and maybe use low tidal volumes. So this was probably the landmark study in JAMA many years ago, almost 15 years ago now. It basically showed that the low tidal volume ventilation, what was good for the goose is probably good for the gander in terms of if we're taking care of our typical patients with low tidal volume ventilation, we should probably be taking care of our potential lung donors in a similar way with low tidal volume ventilation. And nowadays, the management of these patients with low tidal ventilation has become more or less the standard of. Kind of getting late on the hour, and I want to spend a little bit of time on post-transplant care, with the understanding that most of us, including myself, and probably my audience here today, probably does not participate in care of patients after lung transplantation. Most of the care is done in specialized centers, in places where the lung transplantation was done in the first place. So if you're not working in one of those centers, you're probably not going to experience very many patients with lung transplantation. You're probably not going to experience very many patients with the diseases that I'm going to talk about in the next 5 or 10 minutes or so. So I'll try to keep it simple, try to keep it straight, and use this more as a general education rather than, oh, I need to remember all these different diseases that we're going to talk about today. So a little bit about vocabulary. We have a couple of abbreviations, a couple of acronyms here. PGD is primary graft dysfunction. We'll talk about that in a little bit. SLAD is chronic lung allograft dysfunction, basically chronic rejection, just a fancy word. We used to think that BOS or bronchiolitis obliterans was the main representation of that. We'll talk about that in a minute. There's also acute cellular rejection. That's different from the chronic rejection. And that this new and relatively poorly understood antibody-mediated rejection. If you're into immunity a little bit, you may remember the majority of the rejection that happens, whether it's lung transplant, kidney transplant, liver transplant, majority of the rejection is cellular rejection and not antibody-mediated rejection. We're now discovering that patients with lung transplantation also suffer from antibody-mediated rejection. Don't forget that the individuals with lung transplantation are people too. So in addition to diseases that come on transplantation, they can also have diseases that the rest of us have. So yes, primary graft dysfunction and rejection and all of that are important complications and manifestations of lung transplantation, but don't forget that these individuals also get infection and may get some other miscellaneous diseases such as cardiac, renal, metabolic, etc. So PGD, primary graft dysfunction, it usually happens in the first week of transplant, gives us severe respiratory failure. It's basically ARDS of the graft. It's basically something went wrong with the transplant. It's usually immediate post-transplant. This will become a very common theme. Must exclude, before you make a diagnosis of primary graft dysfunction, must exclude volume overload. These patients will often be volume overloaded. Acute rejection, common. Infection, very common. Other types of surgical complications. And when we come back to kind of quick overview of how we take care of the post-transplant patients, you'll realize that this is very much a recurring theme. Rule out A, B, C, D, E, and then we can talk about maybe it's the lung transplantation related complication. But the risk factors for primary graft dysfunction is suboptimal recipient, or maybe suboptimal donor, or maybe suboptimal organ handling. So basically something went wrong in the process. Management is usually supportive. Again, lung protective ventilation and maybe ECMO, assuming that you're in a center, you're in the lung transplant center, so readily available. So many of these patients. And I'm moving gears a little bit rather quickly. We'll talk a little bit about acute cellular rejection. Typically happens between 1 week and 1 year post-transplant. It usually has non-specific signs and symptoms, shortness of breath, cough. Chest X-ray and CT scan will be non-diagnostic. Really, for diagnosis of this particular condition, we need transbronchial biopsies. Usually transbronchial biopsies are sufficient. However, we need at least 5 biopsies, and we're looking for neutrophil-rich infiltrates on histology. So again, relatively sick patients will have to undergo bronchoscopy with multiple biopsies. Not a fun type of intervention. Immunosuppression, usually steroids, is the mainstay of treatment, and this becomes a major risk factor for chronic rejection or CLAD. Antibody-mediated rejection is a very new concept and very poorly understood concept, and unfortunately carries a very, very prognostic value. So most of the, about half of the patient with antibody-mediated rejection will be dead 1 year after diagnosis. A couple of words about CLAD, and hopefully we'll finish maybe 3-4 minutes prior to the hour. CLAD is a new word or new concept for chronic rejection, and I think that the idea behind chronic rejection was that chronic rejection used to be of obstructive type physiology. Okay, so we used to say that bronchiolitis obliterans, which is obstructive lung disease, which is a version of obstructive lung disease, was basically the manifestation of chronic rejection. However, nowadays there's a number of individuals with this pattern that are seen as well. So now they separate 3 different types of chronic rejection: obstructive versus restrictive versus mixed. Persistent decline in FEV1 greater than 20% will be the sign of chronic rejection. We have to make sure that there's no identifiable cause. Again, rule out infection, rule out CHF, heart failure, rule out PE, and if everything rules out, then we can talk chronic rejection. Treatment is usually immunosuppression, and something that I'm not talking about at all today. Obviously, this is a little bit of scope from for us here. Basically, you blast them with various immunosuppressants and hope that you cool off the rejection, killing the patient. A couple other honorable mentions or not notable mentions for patients with CLAD. And it's very interesting that individuals with chronic rejection will benefit from amikacin. Not about the antibiotic action of it. Somehow this medication, azithromycin, happens to be immunomodulating. There's some excitement about Montelukast, some excitement about antifungal treatment. A more important one is about GERD treatment, the reflux, the gastroesophageal reflux disease treatment, and even more about preventing the aspiration. You have to remember that these individuals after lung transplantation, they're at very, very high risk for aspiration. All three are done. So it's important to make sure that they don't aspirate, complicate their chronic lung rejection with either GERD or a major aspiration. Infection is a big part of these individuals, and there's a whole host of agents that can affect them. And you always have to perhaps first think about infection as a cause of inflammation, but many times individuals will be on some type of infection. This little slide, this little table, again, relatively old, but kind of highlights why people with lung transplantation eventually die or eventually succumb to their disease. And most of these has to do with things like graft failure, infection, and then there's this big category of other. So as I said in the beginning, in many situations with lung transplantation, we're replacing one disease with another disease. And don't forget that many patients after lung transplantation will carry a significant amount of morbidity and mortality with them. And therefore, the decision to send someone for lung transplantation has to be made with, heavy heart. I like this little diagram because it kind of visually represents various complications that we typically with lung transplantation. And unfortunately, this is relatively old slide. So instead of chronic rejection, here we have BOS, bronchiolitis obliterans syndrome. Remember that that's not the only manifestation of chronic rejection. So think of BOS, replace BOS on clad chronic rejection, if you will. But it kind of highlights what type of things we deal with early on, like first weeks to months of lung transplantation, what kind of things we deal with first year or so, and then what's happening in these patients. So I think this is a nice visual representation of various carry over throughout their life. Here's a big complex slide on algorithm to approach someone with shortness of breath or with respiratory symptoms of the patient. I'm not going through this algorithm. The only reason when I'm showing this algorithm, I highlight two things. First is try to rule out all the other possible why this individual may be declining lung function, starting from pneumonia, infection, bronchial stricture, pulmonary embolism, sort of things that not necessarily associated with lung transplantation. And think about acute rejection if it's indeed in the first year or so of transplantation. And if that doesn't pan out, and you really have to think about chronic rejection, things like bronchiolitis obliterans syndrome, and again, replace BOS with flat here, chronic rejection basically, and look and treat GERD aggressively. So wrapping up, kind of use the entire hour, unfortunately, but summarize things a little bit. Remember that lung allocations change the landscape of lung transplant allocation. Now we transplant patients with IPF, a lot more than we transplant patients with COPD. Timing of the referral depends on the nature and severity of the lung disease. Donor lung treatment, very similar to the routine ICU management, and we always have those individuals from sharing network to guide us the right way as to how to manage these patients. And then we did a brief overview of post-transplant complications, and I understand that many of us probably don't interface with these patients very often in our day-to-day practice, but I thought I'd give you a little bit of a broad overview of that topic. So with that, I'll finish this presentation, and I don't know if we have things in the Q&A or you guys are mostly using that for registration purposes. Let me open that Q&A for a minute and see if you have any burning questions to be answered.